don't think we could have planned the sequence of the lectures any better. Myra and I, we work a lot with many patients, but this is clearly a big issue, dementia, and we're working together with our audiologists to really figure out ways in which we can restore hearing, a major risk factor for dementia. Next slide, please. So hearing loss is a fact of life. There are many variables that contribute to the extent of hearing loss, but the condition of hearing loss is essentially guaranteed as we age. There are various severities of hearing loss. We have mild, moderate to severe, and then severe to profound. When you have more severe hearing loss, next slide, you start having more issues in terms of conversational matters. So many patients will have hearing aids. They will overall do pretty well, but then sometimes they don't work well. And you start having issues with socialization. They're not able to hear conversations, and they start to isolate. And we all have family members and friends that we know that start to fall into the difficulties with hearing, speech, and conversations, and they begin to withdraw. Next slide. So the association with dementia has been actually really well studied by ENTs up at Hopkins. Frank Lynn in particular, he just completed a New England Journal review on this, and it's really staggering when you look at the near linear correlation between moderate hearing loss and increased risk of dementia 3 times, and then dementia with 5 times with severe hearing loss. So these are the patients that I'm interested in with cochlear implants. These are the patients that won't get benefit from hearing aids, and many times they end up in their drawer. Next slide. So the patient that is a cochlear implant candidate is one in which they have severe to profound hearing loss with loss of benefit from hearing aids. Unfortunately, there is a 10-year lag, and as we saw with the earlier talk, there is quite a bit of damage that's being done to the brain, either from genetic predisposition to Alzheimer's, but then you add on to this accelerant to the underlying processing. So we want to be able to identify these patients, and it's very simple. All you really have to do is ask the patient, are the hearing aids working? And if they aren't working for them, they need to have a cochlear implant evaluation. And it's a process that takes about 40 minutes. There are several audiologists that we work with, and they can give you a pretty good idea as to whether or not they will benefit from a cochlear implant. Next slide, please. So the technology with the cochlear implant has evolved tremendously in the last 30 to 40 years. So really, it used to be where you had to drill a well in the side of the head, a temporal bone, and really quite a big operation, big incision. Now it's about a 3 or 4 inch incision and very little drilling, hour surgery, outpatient. This is something that patients can tolerate up into their 90s, as long as the heart and lungs are fine. There's no upper age limit. And we've seen already improvement in cognitive decline, social interaction, and it really improves their ability to interact with patients. A lot of my referrals are from neurologists, and patients do have substantial improvement in their interaction with their family members. Next slide, please. So when I talk with patients, 90% of what I'm doing is dispelling a lot of the myths. So it's a minimally invasive operation. You can't see the incision. It's tucked behind the ear. We don't shave any hair. It's not brain surgery. It's MRI safe, extremely low risk to the facial nerve and meningitis. The risk of meningitis was from a technique and a type of implant that was used that's really now off the market. And as you can see, these implants keep getting thinner and less obvious. So I will say that this is a really important tool that exists. We can do it. It's very well tolerated by many patients. And I think with all the new data that we're getting on dementia, this is definitely an option that we need to get out to patients. Thank you.